I am so honored to be a part of this conversation. I always learn from these conversations. So I just really want to thank each one of the presenters that went before me, and also thank Dr. Kane for inviting me to be a part of this. I'm going to spend a little tiny bit of time talking about social work because in my experience, even though we've been a profession since the turn of the last century, there's still lots of misconceptions about who we are and what we do. So this is just gonna be a thumbnail sketch. I'm not gonna spend too much time in teacher mode, but I do wanna do this just to provide a little bit of context for some of the remarks that I have following. So one of the things that I wanna say, and I don't have data in these slides, these are just prompts for me to think about bigger concepts. One that I would say fundamentally, social work is about thinking from case to cause, meaning that we're change agents and wanting to help and assist individuals, families, and communities, but we're always looking at where we can also influence and be change agents for policies and systems that are not supportive of health and well-being of the families and individuals that we're working with. So we're not just working on case by case by case, but we're looking at some of those root causes. A little bit of a history lesson. To the left is Jane Addams, and to the right is Mary Richmond. These are the established known founders of the social work profession back in the late 1800s and early 1900s. And they really represent the two streams of social work. So Jane Addams was very much associated with the settlement house movement in this country. I think very connected to some larger social movements that social work has been involved in. So, you know, ending child labor, looking at sanitation, really big public health movements. And Mary Richmond is the other side, where she was very much interested in working with families, and it was a case study approach. So it's always been interesting to me that it was Mary Richmond who was really focused on individuals, who said famously, the good social worker doesn't go on helping people out of a ditch. Pretty soon she begins to find out what ought to be done to get rid of the ditch. And actually, I think she said to get rid of the damn ditch. So that's just a little bit about who we are. And I would not be doing my job at the Council on Social Work Education, which is the ACOM for social work education programs, if I didn't just put a plea in for anybody who is at a school of osteopathic medicine or in a medical practice. If you are not connected with the schools of social work in your area or in your same institution, or have social workers on your interprofessional team, I would recommend that it would be a good idea to do that. So I was asked to think about how racism is affecting our societal health, which is no small task. And I've put up this book cover from Ibram Kendi's book, How to Be an Anti-Racist, and really looking at the challenge to, you know, the opposite of being racist isn't not racist, it's being an anti-racist. And if you're not an anti-racist, then you really need to think about ways in which you're complicit in and supportive of racist institutions and practices. We're experiencing what I would say is a very long overdue reckoning about the effects of institutional and systemic racism in this country. And I hope that we have the will to see this through more deeply than we have in the past, because what needs to be changed is not window dressing by any stretch. We really need to be willing to examine very critically the institutions and systems that we are in fact a part of, have been raised in, have been educated in, work within, and so forth. We need to be able to examine ourselves, that this is not just a matter of identifying some of those bad actors perhaps, but really looking at a systemic problem. There's a group of people that have advocated for a while for racism to be named in the Diagnostic and Statistical Manual, which is the sort of Bible of mental illnesses. Because the argument is that racism is a mental health problem. And I want to say that while some racists might have mental health problems, racism is actually a public health problem, and it needs public health approaches. So it's much broader than that. And it's tempting, I think, to look at some individual bad actors, but we would not be making the kinds of systemic changes if we followed that approach through. The truth is that during this reckoning, I know that Black and brown people have not been surprised that racism still exists. You've heard our previous speakers speak to that. In fact, racism has been alive and well. Black and brown parents have needed to talk to their children about how to survive in a racist system. You heard some of that from Chantel in terms of, you know, how Black students and brown students are sometimes taught that they need to be better than or work harder than, they need to be the examples of in order to be seen as just as good. So we've put a tremendous amount of pressure on our students of color. It's also, you know, there is the conversation among many Black and brown parents where they need to have a conversation about, in order to stay safe, quite frankly, to stay alive, these are the ways that you need to act. And that is such a sad, sad fact that parents have to have that kind of conversation with their children. But that is exactly the kind of system and society that we've been living in. And we have an opportunity to change that. You know, when I was thinking about my remarks, I remembered a dear friend of mine, Larry Davis, is the former dean at University of Pittsburgh School of Social Work. And he has written about and spent a lot of time talking about the whole concept of resiliency, which was a concept that we all sort of fell in love with a few years ago, that we needed to understand how people who have been through difficult, challenging times and survive, what can we learn from those people so that we can sort of inoculate others, can build our resiliency, you know, skills and muscles and so forth. And his take on all of this is that it should not require anybody to be extraordinary to be successful. That resiliency, even just the concept, kind of turns things around. It's like, okay, so let's reward the ones that somehow managed to survive the racism, the abuse, the implicit bias that we just heard about. I mean, just any number of explicit and implicit barriers. That is not the way to address a problem. It's really looking at what system requires extraordinary reactions just to survive, just to be successful. That's the kind of, you know, that's the approach that we need to take with all of this. You know, most of the efforts that we make in the healthcare system are downstream. So, you know, to harken back to Mary Richmond's quote, you know, we look at treatments and interventions and things when people have presented as needing our assistance. This effort is going to require us to move upstream, to really think about the kinds of ways in which our systems have been built to only support wellness in some people and to make that more challenging for others. This is not just a matter of access and quality of health. It is also about the ways in which we have baked all of this into our systems. Thrilled that our healthcare professions are all talking about the importance of social determinants of health and looking at ways in which we can rectify health disparities. In the words of one of the deans in the School of Social Work that I work with, you know, looking at these days to talk about the need for diversity and inclusion, and this is all due respect to all the people that have talked about diversity and inclusion seriously, but this one dean said, you know, it's kind of like sounding like hearts and prayers. Our love and prayers are with you right now. Like, we need to do better than that. You know, it's not just about diversity, but it's becoming the anti-racist that Ibram Kendi is really challenging us to be. I was part of a panel recently, and there was an African-American woman on the panel who, after speaking for quite some time, she just sort of sighed and said, you know what, being Black in this country is a pre-existing condition. Right there. She said it. It's a pre-existing condition for a number of things that make it more challenging for her to live her life fully and well and connected and all the things that we care about. So I just want us to think about that. Social determinants of health, in my mind, has always been a bit of a code for race and poverty. That those that are affected by the social factors that impede a full and well-lived life are factors in the lives of more Black and Brown people than any other, and we need to be thinking about that. In order for us to move forward, and I'm going to keep my remarks because I know that this program has gone on longer than Dr. Kane originally intended, and I know that there are lots of questions and comments, but in order for us to be able to move forward and not lose the will for the kind of structural change that I think we've all been talking about here, is that we need to be able to engage in some non-defensive and dispassionate conversations about these things. One of the most powerful metaphors that I read years and years ago now was Beverly Daniel Tatum in her book, Why Do All the Black Children Sit Together in the Cafeteria? By all the Black kids. And she talked about racism being a smog, that in certain weather conditions, smog is very apparent. There are times when I'm out in the West Coast where you see more smog than on the East Coast, and certain humidity factors and what the barometer is doing. I mean, it's very apparent, it's visible. But there are other days when it looks like it's a clear day, but we're still breathing in the smog. That's exactly what racism is. When sometimes it's extremely apparent, and sometimes it's just in the air that we're breathing. So it's never just going away. And it would be tempting for us to think that we can just do some window dressing kinds of changes and then we'll be good. But I don't think that we can afford as a country to do that anymore. I feel like we really need to be able to fearlessly examine ourselves and our institutions in order to make the kinds of changes, to make the principles of this country a reality for everyone. And that has not been the case. It's going to be hard. It's going to be very, very uncomfortable, and we don't like to be uncomfortable. We don't like to make other people uncomfortable. But I think that that's what is going to be required for all of us, and we can do that. I mean, we will create the world that we want to create. And so what's really on the line right now are our values. So I hope that this is not a Groundhog's Day, that tomorrow we wake up and everything's the same and we get to start over, but we have an opportunity to really create a different future for all of us, and for our children, our patients, our communities. So thank you. I'm looking forward to the final speaker, and I'm going to pass that on to, I think it's Dr. Smedley now.